The patient is not going to do what I told them to do. No, they're not going to do that. Unless we figure out how their dog can have care for 3 or 4 days and they can feel comfortable with that, then they're not going to voluntarily be admitted to the hospital. They come to see you in the clinic. Those are the things that are going to be on their mind. So you learn to be a good steward of the patient's time and resources, and also of the healthcare resources.
What is the actual difference in roles between an RN and an NP?
When the light goes off, everything changes. When it clicks, when they transition from thinking like a registered nurse that works primarily at the bedside to a nurse practitioner, someone that's diagnosing and managing diseases and care. I mean, as nurses, we do care for the patient holistically, but it's very different caring for the patient in the hospital than caring for the patient in the community.
Welcome to the My Career Shop podcast. Today with me, I have Dr. Dorothy Murphy, who is a nurse practitioner. Welcome everybody to the My Career Shop podcast, where on each episode, I get to speak to people from different professions so you get an idea of what actually happens in the day-to-day of different careers to help you find out if this career is the right path for you. Today's episode is special as I get to learn about the #1 ranked job in the United States per the US News Best Jobs ranking. What is that job? It is that of a nurse practitioner. And our guest for this episode is Dr. Dorothy Murphy, who has 20 years of experience as a nurse practitioner and 13 years of experience in education and leadership. With a passion to improve the health of individuals and populations and to develop professional nurses who embrace nursing as a ministry of care and service, Dr. Murphy came to fill us in about everything with respect to this profession, including why it is the #1 ranked job, the various routes and steps you can take to become a nurse practitioner, the types of nurse practitioners, essential information that will impact your ability to land a job once you finish the nurse practitioner program, the accreditation exams, what a nurse practitioner actually does on a day-to-day, the difference between the master's and doctoral route, their salary, and a lot of advice to help anyone to join this profession. So if you're looking to find out how to become a nurse practitioner and what to expect once you actually become one, tune in for the rest of the episode. Well, welcome to the My Career Shop podcast. Today with me, I have Dr. Dorothy Murphy, who is a nurse practitioner, and we'll be talking about this a lot, but for all the audience, nurse practitioner is ranked the #1 best job in the United States. So we are here today to learn about one of the best careers that you can enter in the United States. Hi, how are you doing, Dr. Murphy?
Oh, great. Well, thanks for having me today. I'm doing awesome, and I'm so excited to talk to you about this #1 ranked job in America. Not just the #1 ranked job, best job in America, but also the best job in healthcare and the best job in STEM. Not quite the best paid job, but there's lots of benefits that lead people to this career, and it's just a very rewarding career. So I'm really excited to be here today and talk to you about it.
Awesome. And when you say STEM job, what do you mean by STEM?
Science, technology, engineering, and math.
Oh, okay.
Yeah.
I knew that. It's just for the audience. So how many years have you been a nurse practitioner for?
I've been a nurse practitioner for almost 20 years.
20 years. Wow.
20 years. Yeah, I was an early nurse practitioner as far as the profession goes and its advancement in autonomy. When I was in NP school, nurse practitioners could not prescribe medicines.
Oh, okay.
So I've been around for a while. Yes.
Okay, fair enough. So you got into the profession when it wasn't even the profession, but how did you get into it?
Well, my mom is a nurse, and so the nurse practitioner role is it's very distinct from medicine in that the concepts of nursing do underpin everything that we do with a patient. So first and foremost, I am a nurse, and that's how I entered the nursing profession. My mom was a nurse. I was around nurses my whole life. I was around physicians my whole life. I was around the hospital, around sick patients, hearing about patients becoming well, those not. And so nursing was around me my whole life. So there was a point in time where I said I would not be a nurse, only because I saw how much, my mom gave to that, and it just seemed unreal, the amount of energy and time that she spent. Really, it was a service, a ministry. It was beyond a job for her, and so that was very intimidating. So I was a nurse. I got my RN in 1999 is when I got my RN license. I went to an ADN program, a 2-year ADN program, and
ADM stands for?
that's for an associate degree in nursing.
Okay.
So I got my associate's degree in nursing first because there were no 4-year degree programs in our area. And so I did it the first 2 years, got my associate's degree, and then I went back and got my bachelor's degree. I did know when I was doing my bachelor's degree that I would want to eventually do something in advanced practice, but I really was not sure what that would be. I'd considered the nurse anesthetist role versus going on to medical school. And it was in my bachelor's program when I was actually working as a nurse that I just contemplated, those options. I had a young family. I was working full-time as a nurse in the acute care hospital setting, and figured out pretty quickly within the first couple years a couple of situations that really pointed me to, yes, this is the career trajectory I would like to proceed with, because just the experiences I had as a nurse. One of those experiences, there are two actually that I'll just never forget that really pointed me to being a nurse practitioner. And the first one is that I had a young male patient. He was 35. His name was Michael, and he had 2 adolescent sons. I'll never forget. And I took care of him in the medical surgical unit. He had pneumonia, a simple case of pneumonia. And I took care of him for 3 days in a row. And so that's not as common. It wasn't as common for me because I floated all units as a nurse, had all kinds of experience across different populations and settings. But this particular patient I'd had for 3 days, and he was there, and every day his wife was there and his 2 young children. I think they were probably 12 and 10, and he had pneumonia, and that was probably 2000. Yeah, probably around 2000. And he became very ill, and he passed away from pneumonia. And I just thought, in the year 2000, a young, healthy man should not pass away from pneumonia. So I had a lot of conversations, before he got really ill with him and his family about, why, because he had been ill for about 2 weeks before he came to the hospital, and about what it was that caused him to wait so long to seek care. And we were in a rural area in rural Appalachia. He did not have health insurance, and healthcare providers were sparse in the area, and he just did not have, we would call that access to care now. And so he did not have the access to care, and it was really, it was impactful to me that that in the year 2000, someone didn't have access to care, a young, healthy man with 2 kids, and died of pneumonia. It just didn't seem like that should be the case in that time. So that caused me to think about the healthcare system as it is, and where we can really make the most impact for patients and improving their health. And it's really in the community. It's not in the hospital setting. Once they get to the hospital, they have to be pretty sick to be admitted to the hospital. And then, our statistics, once they're admitted, from them acquiring hospital-associated infections, medical mistakes, and things like that, it's just not the safest place to be, unfortunately. So I wanted to be impactful before they got to the acute care setting, to be able to be in the community, to know patients, to see them on a regular basis, and to be able to impact their health before it got to that point. So that was the first situation that really prompted me to rethink my career in the acute care setting and what I was doing there. The second was I was working as a registered nurse, and like I said, I was in the float pool. And so what that means is, as a registered nurse, I was trained in all units of the hospital. I was trained in the emergency room, and the psych department, and medical surgical, and the telemetry, so the cardiac patients, and the intensive care units, the newborn mother-infant unit, and the NICU. I was trained in all of those units and worked across the hospital for 2 years. So the next instance that really caused me to rethink my career trajectory was that I was working in the intensive care unit, and in the intensive care unit, it's a great it's a great place to work in that you have the ability as a nurse to focus on one or two patients, and I had my two patients that I was taking care of, and then there was another nurse, several of the nurses, they all had their own patients. And so I was done taking care of my patients for the moment and just monitoring vital signs, all of the record documenting. And one of the older nurses came and asked me if I would help her lift her patient up in the bed. And the nurse was probably, I was probably 22 at the time, and she was close to retirement. So probably getting close to 60. And I'll never forget when I went to my side of the bed to help lift the patient up. And when I lifted the patient up and I looked across the bed at the nurse, and just the expression, the fatigue, and the weariness on her face, and just how difficult it is to physically to be a nurse, I wasn't sure, that it would be something that I could continue to do at her age. And I was so impressed with her being able to do that. But to me, that didn't seem realistic from a lifespan perspective. So those were the two things that led me to consider being a nurse practitioner. And I decided in my bachelor's program to go to a master's program. In our area in Appalachia, there were no programs within 2 hours. So we, myself and one of my nursing colleagues, we traveled 2.5 hours once a week to a state university. We both had young families, and we traveled once a week to go to class for 3 years. But we did that once a week, and then we had certain classes where we would be there for like the full week.
So did you go there and come back the same day, or you stayed somewhere?
Yeah, and they had evening classes, which was really great. At that time, there were not online didactic programs. Everything was residential, though we did have computer work. We did our assignments online, but our lecture, our exams were all in resident. And so that's how we traveled there for 3 years to get that degree. And it was much needed in our area. Like I said, we were in a very underserved Appalachian region. And so it was definitely a calling for both of us at that time. Yeah.
That's very interesting. So your first experience, I had something similar to that, but it took me the complete opposite direction. So I was back in the good old days when I was doing my undergrad, I used to also volunteer at a hospital. And one day a patient came in, probably somewhere between 35 and 40, and he also had 2 kids, and there was a code blue, and all the nurses, all the doctors jumped over this guy to try to keep him alive, and he passed away. And just the morale and everything that entire day, it was just awful. And I was, I think, 19 at the time. And I was like, I don't know if I'm made for this field, So I had the complete opposite reaction, because before that, I used to also volunteer in an old folks home. And so I did that for a long time. And then I spent, I think, 2-3 years volunteering at a hospital. I don't remember how long, but I was like, I don't know if I'm cut for that. So it's interesting that you had the complete opposite.
Well, I was already a nurse.
Yeah, that's true as well.
And it was my life. It had been, so much of who I was and what I knew, being that my mom was a nurse and I grew up around that community. My mom gave me my career, the best and the worst career advice I ever had. And I know we'll get to that later. But that really is what it made the difference for me. Like I said, there was a short period of time where I considered not going into nursing. And I actually looked into like business or accounting, and I took one class, and I was like, this is not for me. And I knew then. I was like, no, you can't run from this. This is, who you are and what you're called to do.
Well, that's awesome. And you're happy.
I am, absolutely. It's the best job, #1 job in the United States.
Yeah, that's what matters. All right. So now that you're nurse practitioner, how long were you a registered nurse for before you became an NP?
Well, I am still a registered nurse.
Oh, okay.
Okay, so all nurse practitioners have to be a registered nurse. So I worked as a registered nurse for 5 years before I was a nurse practitioner.
So before we continue,
Yes.
is that actually a requirement? Because
Yes.
there's some direct entry programs.
It is a requirement, and even in
okay.
those direct entry programs, the student will get a nursing degree and
okay.
sit for an NCLEX and get licensed as a nurse, a registered nurse.
Okay,
Yes.
so you have to become a registered nurse before you
Yes.
become an NP.
Yes.
And you were a nurse, you practiced as an RN.
That's
You're still an
correct.
RN
That's right.
for 5 years.
That's correct.
Before you went to school or became an NP?
Before I became an NP.
Oh,
yes.
okay.
Yeah. I did 2 years of my associate's degree, and then I started working as a nurse full time. And then while I was working as a nurse full time, I got my bachelor's degree, which was a prerequisite for a master's degree. And so then I did a 2 plus 1.5, so it was 3.5 years of nursing school. And then I went to my master's, which was technically a 2-year full-time program, but I had a young family, and so I did my master's over 3 years.
Okay. Now, if anyone wants to know how to become a nurse, check out episode 6, because Dr. Akers went into great detail about all the different routes about how to become a nurse. From that, I remember there's 3 routes.
Mm-hmm.
There was the associate's degree, the second one was bachelor's, and the third one was the diploma. Now, the
Correct.
diploma is getting phased out from what I recall.
That's right.
But if you were one of those folks that did a diploma, you would have to get
A bachelor's.
a bachelor's.
That's correct.
And so there's no other way to apply for the master's unless you get a bachelor's in nursing.
You can apply. Some master's programs actually are what we had discussed a little bit, what were called direct entry or an accelerated program, to where you come in as a second degree student. Perhaps you have a bachelor's in business or biology or biomed, some other bachelor's degree, and you come into the program, into a direct entry program, and during that program, you become a nurse. And you do the undergraduate nurses training, and usually that's about 1 year, 12 to 18 months in nursing education and clinicals, so that you become deemed competent and are eligible to sit for the NCLEX exam. And then during that time, a lot of these direct entry and or accelerated master's programs for advanced practice, like a nurse practitioner, is based upon that. You've got a bachelor's in another degree profession, another degree program. You enter, the first year is the basic RN, didactic and clinical. You take your test, and then you go into the master's, the advanced practice, didactic and clinical, and then you finish up.
Okay. So, you said you did your master's part-time over 3 years.
That's correct. Yes.
If you were to do it full-time, it's how
2
long?
years.
2 years.
Yep.
Okay.
And that was 2 traditional years. That was, in the fall and spring, there were not summer classes unless, you were in a quartered system. So that was 2 years full-time would have been like a fall and a spring. Now, master's programs can be online, and the majority of them are, and there's the option to take accelerated courses. Some of the courses are heavier loads, they're only 8 weeks. You can take them throughout the summer, and so you could get a master's in 18 to 24 months if full-time. Though at the advanced practice level, at the master's level, having 20 hours of credits is not the same as having 20 undergraduate credits. So
what's the advanced practice?
Advanced practice is we call it advanced practice registered nurse. That encompasses all nurses that have a practice beyond the scope of a registered nurse. They're either educated and or licensed, certified at an advanced level. So in the United States, we have several different types of advanced practice nurses. One of those is a nurse practitioner. Another one is a nurse midwife. Another is a nurse anesthetist, and then a clinical nurse specialist. So those are the 4 main advanced practice nursing fields. They have advanced beyond the bachelor's and the RN, the bachelor's degree and the registered nurse license. They have an advanced practice, either in, like I said, being a nurse practitioner, anesthesia, midwife, or a clinical nurse specialist. So my advanced practice degree is as a nurse practitioner. And then as a nurse practitioner, you can be a family nurse practitioner, which is the majority of nurse practitioners. Almost 80% of all nurse practitioners are family or primary care nurse practitioners. And so what that means is you're educated and you're certified and you practice in a patient population that is from birth until death. Except for labor and delivery. I don't deliver babies. And then the midwife is their scope, they're educated, certified, and their scope of practice is for females delivering babies, and I believe up until the first few weeks of life for the baby, they can take care of the baby. Nurse anesthetists, they're educated, certified to administer anesthesia.
Oh, okay.
Okay. And then a clinical nurse specialist is they are a nurse that works in most of the time in the acute care setting, in the healthcare setting. Oftentimes they cover several different units, and they are I would say a bridge between nursing and the frontline nursing and medicine and or the other ancillary services in the hospital, and they provide a lot of oversight of care of patients that are complex in the hospital system and that need a lot of coordination of care within the acute care system.
Wow, that was cool. So now I have more people to ask.
That's right. That's right. Yes. Yeah. But focusing on the nurse practitioner, yes.
Yes.
Yeah.
So just one question. I didn't realize that there was an advanced nursing program for anesthesiologists.
Yes. Well,
and these guys can administer anesthesia.
a nurse anesthetist, actually, a nurse anesthetist it was one of the earlier advanced practice nursing programs. It was actually it was more common for nurses when I was graduating from nursing school and looking at advanced practice. There were more nurse anesthetist programs and opportunities than there were for nurse practitioners in my region. But yes, so they have a bachelor's degree in nursing. They are registered nurses. They go back to an advanced degree program to a master's program now. It used to not be a master's, it was a certificate program, but now it's a master's program, and they are fully educated, trained, everything surrounding perioperative anesthesia care, and they do administer anesthetics.
What's perioperative?
Anything from pre-op. So they take care, they assess the patient before surgery, they monitor the patient, assess the patient, treat the patient with anesthetics during surgery, and oftentimes they manage post-operative pain management. So they take care of the patient all throughout that period while they're during their surgical care. Yeah.
Thank you for clarifying.
Yeah, absolutely.
I don't understand the lingo.
Yeah.
Maybe in a few years, after I get enough people in healthcare.
But yes, the nurses do administer anesthesia. Yes.
Wow. That's very interesting, because I was under the impression that becoming an anesthesiologist is one of the most lucrative careers, even within medicine.
That's right.
And then I'm guessing this is also a very lucrative part to nursing.
Much. Yes, absolutely. Right? It is one of the higher paid advanced nursing careers, yes.
Okay. So now I want to actually discuss the exact steps to becoming an NP. And I know we've covered a little bit already, but so first and foremost, you have to become a registered nurse through one of the routes. Check out episode 6. After that, is there a prerequisite for how much time you have to spend practicing as a registered nurse before you apply for a master's? Or can you just, bang, you're done, let's say you're done on December 31st of 2023, on January 1st, you can apply? Mm-hmm.
Actually, when I graduated with my BSN and was a registered nurse, there was a practice requirement of 2 years for entry into the master's program. Now we are direct admitting. Even if they are completing their bachelor's and they want to apply, some schools are allowing them to apply and be admitted contingent upon them passing, their NCLEX and being licensed as a nurse. So yes, there are a lot more schools going into a direct admission without a requirement for practice time. A lot of schools still do require at least 1 year as experience, but there are plenty of schools that do not have that requirement. Some of them say you have to have 1 year of practice experience before you enter into your nurse practitioner clinicals or practicum. So usually the first year of NP school is didactic work, and so if a nurse is working, then they'll have a year's experience before they go into
And can you tell
clinical.
us what didactic work is?
Yeah, absolutely. So all advanced practice nurses, all master's degree nursing programs, we have a national accrediting, we have a national professional body that sets the standard for education in nursing. And so all master's programs look very similar in that there's research, there's theory, there's what you heard Dr. Akers talk about is the 3 Ps, and that's advanced pathophysiology, advanced pharmacology, and advanced health assessment, physical assessment. And so we have that first year is that's what the foundation is. Theory and research it's really focused on nursing, and the research is focused on not really preparing you to be a researcher, though it is a foundational stepping stone. It is really so that you can be a competent, productive member of the healthcare system, medical community, and that you can read and interpret research studies, and so that you can apply that knowledge to practice.
Fair enough. So that's the didactic work that you do in the first year, and then in the second year, you said it was the practice, or
you do have practicum, and there are still didactic classes. They are what we call as population focused. So as a family nurse practitioner, like I said, I have education and certification license to practice to care for patients across the lifespan. So during that second year, they're getting the care, the diagnosis and management of health and disease in each of the populations. So we would have a pediatrics course. You'll have a women's health course, and like some programs divide adult into acute, like meaning self-limited healthcare problems, common things like urinary tract infections, ear infections, well of visits, things like that. That would be self-limited care, and then more chronic care. So care of patients with high blood pressure, with diabetes, with heart disease, with lung disease, asthma, COPD, things like that. So the second year the education is typically surrounding the population care management. Yeah.
Okay, so
And
let's go back.
Yes.
Yeah, so we become a registered nurse. There's no longer much of a requirement, so you can technically enter right after, and then you apply for a master's program to a university that offers that program. You have to undergo 2 years full-time or 3 years part-time, or I'm guessing it could be even longer, depending on how slow you want to go. And then you become a nurse practitioner?
Then you can become a nurse practitioner with a master's degree, yes.
Okay.
And there are, 20 years ago, actually longer than that, 40 years ago, nursing realized there's been advanced practice nurses, but they didn't have a master's or a doctoral degree. They had certificates. There were nurse practitioners in the West in very underserved areas that there were not physicians that were seeking to go live in those rural areas, and there were a lot of nurse practitioners. That time they weren't masters or doctorally prepared. They had completed training programs, and they had gotten a certificate, and they were practicing as nurse practitioners. That was 40, 50, 60 years ago. Now, along the way, the profession of nursing said, really we shouldn't have those certificate programs. There really needs to be a more robust education for advanced practice. And so develop the master's programs. But even since then, there's been a push for a doctoral program for nurse practitioners, advanced practice nurses to be prepared at the doctoral level. And that doesn't mean that they're physicians. That means that they have more education in nursing, advanced practice, in leading healthcare at the doctoral level. So there used to be a doctoral degree called the Doctor of Nursing Science, and that was supposed to be the practice doctorate for nurses. And that ultimately turned into a research degree. So they were doing bench research, not really leading in healthcare at the patient level, impacting patient outcomes that we really needed to see in the nation. And so about 20 years ago, they said, guys, we really need to go back to this push to have advanced practice nurses prepared at the doctoral level. So 20 years ago, our accrediting bodies said we are going to stop accrediting master's programs, and we are going to accredit advanced practice programs only at the doctoral level. So there has been a huge shift in nursing education, especially at the advanced practice level, to transition those master's programs into doctoral programs. They have not stopped accrediting master's programs, so that's still a great point of entry for nurse practitioners. But the future is complex in healthcare, and the push still is to have a doctoral degree, and we'll get into that a little bit later. Yep.
Yeah. So we're in 2024. So how would you recommend that someone that's 18, 19, or maybe just starting their bachelor's of science, how would you recommend they enter this profession?
Well, I think it depends upon where they're located. Like I said, many students do not have access to a 4-year baccalaureate and nursing program. I think that is the best well-rounded education for a nursing student to go through. There's, as Dr. Akers talked about, there's lots of research that shows that they are better prepared to take care of patients. And so definitely recommend that bachelor's program if they have access to it and can commit that time to that 4-year program. I think that is the best well-rounded education for a nurse. However, like I said, in my instance, there wasn't a 4-year program for nursing that was within my driving distance. But there were a couple options for associate's degrees. The associate degree option is 2 to 3 years, depending on how long. And then there is option now in 2024 for, if you have an associate's degree, for you to get a bachelor's online. So your didactic work is online. There's still a clinical component where you have to do practice hours and things, but that if you have an associate's degree and you have, a lot of nurses have families or are starting families, then it's a flexible option. But the 4-year bachelor's program, I would say, is the gold standard.
Okay. And then do you recommend that they practice before they become an NP, or do you think it won't matter because there is a practice aspect of the NP as well?
I can see both sides of this. Quite honestly, I think that if they have practiced as a nurse, then it gives them a breadth of experience that is really helpful when they're in their master's program. It gives them a foundation of understanding how to take care of patients with those diseases, and what the patients go through, and not just the patients and their family. So I think it's beneficial. I don't think it's absolutely necessary. I've seen a lot of students come directly from their nursing program directly into a family nurse practitioner program and do exceedingly well. The practice is so different, but the experience of health and taking care of patients is very valuable.
Okay. Well, uh, from my perspective, I always feel like having some practical experience before you enter additional theory,
Yes.
it always helps,
It
because
does. Yeah.
what I've noticed in my life is that I studied a lot and there was a lot of theory that went into my brain, but I really didn't understand the implications of it. Then all of a sudden I was thrown into practice, and then all these theories and, all that stuff came back to me at that point, which I never really understood during class. So I would be under the impression
Mhm.
that practicing a little bit would help.
It does, absolutely. There's no doubt about that. It does help. Though, because the practice is so different, and the training is very rigorous for a nurse practitioner, that I don't think it's not an absolute necessity, or it would be an absolute requirement for all nursing programs. But I agree. It really is very helpful for them to come in. I also have seen the other end of that, where I've had, because as a nursing faculty, I was students first, second, third year of family nurse practitioner program. Um, you know, I taught health assessment. I was able to actually see that when the light goes off, everything changes. When it clicks, when they transition from thinking like a nurse, a registered nurse that works primarily at the bedside, to a nurse practitioner, to someone that's diagnosing and managing diseases and care. And so I've also seen on the other side of that, where I've had students really struggle, who have been bedside nurses, ICU nurses for 20 years, and they want to go back to NP school, and they really struggle with the concepts of primary care across the lifespan, holistic care. I mean, as nurses, we do care for the patient holistically, but it's very different caring for the patient in the hospital than caring for the patient in the community. Totally different engagement. I always would tell my students that were nurses, when you have a patient that's admitted and they are ill and they're in the bed and you've got them connected to all of the wires and the tubes and you're giving them their medicines, you're feeding them, that patient is very dependent and is very compliant with everything, that all the care that's being provided them, because they're very ill and they need to be. But whenever you are collaborating with people in the community to achieve health, it's a different story. You have to think about how to be a good steward of their time and their resources, and they have many more opinions when they're feeling healthy and well than they do when they are laying in a hospital bed. So they think about things like, and that's really that's the heart of nursing, and I think that's why nurse practitioners, nursing is considered the most trusted profession in the United States. It's because we empathize with the patient. We see their experience, not just the disease experience, but how that disease is impacting their relationships, their social, their family, the psychology of disease, their careers. Like we think about the whole human when we're caring for them. And as a nurse practitioner, you take that into your practice, and I think it is great, experience for nurses to have a 1 to 2 years of experience before they go into NP school, because you understand that a lot better, that that collaborating with patients to achieve health. Because as a nurse, one of the things I brought into my NP profession and practice is that I understand that when I make a recommendation for a test, that the patient has to, have transportation that they may not have. They may have to have a family member that attends with them. They may I've heard, patients can't leave their animal. There's been times where I've actually said, you really need to be admitted to the hospital, and there's a lot of resistance, and you can feel that, and you're like, what's going on? And you're like, and you start exploring what's going on with the patient, and or they have a sick spouse at home, or someone that's dependent upon them for care, or again, like I said, this one of the strangest concepts, I think, going from an RN bedside to working in the community, is that patient telling you that they do have a dog at home that no one can take care of if they go to the hospital for 3 days. And so that is their primary concern, that I help them work through, who can help take care of their favorite pet so that they can go to the hospital to be sick, so they be taken care of.
And you're saying that's one of the most frequent thing that you hear?
For me, and not in nursing.
Oh, okay.
What it is in one of the most shocking, I think, abrupt situations, is going from having a patient that has to do everything For the most part, we're going along this plan of care because they are acutely ill to going into a mode where you are negotiating with the patient about what they will and will not do. And it's their decision. I mean,
Wow.
you present, what the problem is, what you've assessed, what you recommend, the options, the risks and benefits for each of those.
Mhm.
And it's ultimately the patient's decision. And I've seen nurses with 20 years experience really struggle with the patient is not going to do what I told them to do. No, they're not going to do that because they are concerned unless we figure out how their dog can have care for 3 or 4 days and they can feel comfortable with that, then they're not going to voluntarily be admitted to the hospital. And so it's just different. And the other thing, coming from an acute care setting where when a patient's admitted to the hospital, their insurance covers, if they have insurance or Medicaid, Medicare, it covers the bill for, it's a we know what diagnostic tests they need. We understand while we're providing care in the hospital that those bills are going to be taken care of. And on the outpatient side, the patient will say, "Well, I have not met my deductible, so I'm not going to do that right now."
Wow.
And so there's, you what you do is you approach practice differently, and you're much more collaborative with patients when you're providing their primary care than whenever you are. And I think that's one of the big transitions for nurses, coming from the bedside to going to primary care as a nurse practitioner, and learning how to collaborate with your patient. You have to become a good steward of resources. You think about how much a prescription costs, whereas in the hospital, it's paid for. And they have not just is it going to cost anything, but is it going to be covered at all? And the patients, when they come to see you in the clinic as a nurse practitioner, those are the things that are going to be on their mind. So you learn to be a good steward of the patient's time and resources, and also of the healthcare resources. Go ahead.
So you said these were some of the things that nurses struggle with when they move over to the NP profession.
Mm-hmm.
So can you elaborate on what is the actual difference in roles between an RN and an NP? And see, I think I might be getting ahead of myself because I think it would probably be better if we discuss what does an NP actually do.
Okay.
But we'll wait because I would love to first get through there's so many different routes
Mm-hmm.
to becoming an NP, right? And you said that so far the best version was Bachelor of Science in Nursing.
Mm-hmm.
Then you said the master's program might be getting phased out. It's still being accepted everywhere,
Yes,
but the more recommended route is doctoral.
to be educated at the doctoral level. The master's programs are not going anywhere
Okay.
anytime soon.
So what do you apply for? A master's in nurse practicing?
It's a master's in nursing,
Oh,
and
okay.
then you can choose which type of advanced practice. Remember, I said there are 4
Yeah.
types. So there are several different types of nurse practitioners as well. So yes, it'll be a master's of nursing into a nurse practitioner program. Again, majority of nurse practitioners are family primary care educated, trained, certified. So family nurse practitioner. Though there are a couple other different nurse practitioners that I think that we should talk a little bit about.
Let's talk about them.
So I explained what I was trained in as a family nurse practitioner across the lifespan. Also, as nurse practitioners, there are population specialties of acute care. And so acute care nurse practitioners work in the hospital most of the time. They work in places like ICU. And it's called an adult gero acute care nurse practitioner program. And so they are educated and certified licensed to take care of patients over 13 years old all the way through geriatrics. And they really focus on those disease processes in the acute care setting. Okay, so that's one type of nurse practitioner. And that's good for a nurse, I think, that wants to stay in the hospital and wants to provide acute care. There's a good demand for an acute care nurse practitioner. Then there are nurse practitioners who are adult gero. They don't want to take care of pediatrics, OB, things like that. They are adult gero, and they start at 13. They to the end of the lifespan, but their focus is in the outpatient setting. So they take care of patients, adult patients in the community. Where I see that role being utilized a lot is in like the VA systems, and in the Veterans Administration
Oh,
systems.
okay.
So because that is an adult population, needs to be very well understood. So the VA hires a lot of adult gero nurse practitioners, and also in the skilled nursing facilities, and any place where there's more of a geriatric focus. Those healthcare practices facilities tend to lean toward that adult gero nurse practitioner. Now, it's not that a family nurse practitioner can't take care of the things. It's just that the adult gero can in primary care. It's just that that's where their focus is, and the adult gero does not take care of the pediatrics. And then there is a psychiatric mental health nurse practitioner who that is really in great demand, and they focus on across the lifespan psychiatric and social diagnoses and disorders and management, strictly the psychiatric treatment of patients, depression, anxiety, bipolar, schizophrenia, personality disorders, ADHD, things like that. That's where they focus their population of studies, and competency is in that realm of care.
Okay, so that's family.
Yes.
Number 2 was acute care, more in the hospital setting.
Mhm.
Third one was adult gero. These guys stay away from babies.
That's right.
And then the fourth one was psychiatry.
That's correct.
Okay,
Yes.
so that's what you get out of a master's in nurse practitioner.
Those are the main four.
Okay.
There are some emerging other focus, like a women's health nurse practitioner. You can go to a master's program and just focus totally on women's health, providing primary inpatient and outpatient care of just women. There are those programs, and more recently there is a education and certification in emergency room nursing as a nurse practitioner. And so it's a different population. There's lots of family nurse practitioners, lots of adult gero nurse practitioners that work in the emergency room, but it's such a special population that it commanded a separate degree that a lot of nurses are going toward and being certified in. But the four main are, yes, what you listed.
So out of the 4 main, is there a difference in salary and
Yes.
I mean, I understand lifestyle because you already broke it down. So family practitioners work where? They work at their own medical office near in a community?
They do. They work in healthcare systems,
Okay.
in medical clinics and physician-owned clinics and healthcare system-run clinics. They own their own practices. Some of them do. They work also in specialty care. Like, for example, I'm a family nurse practitioner. I did work in primary care in a physician-owned practice for 2 years. And then I went into cardiology, and so now I work in a cardiology clinic. And so that's the family. There's lots of opportunities. Family nurse practitioners can work in the VA. They can work in the psychiatry field, though they are not certified in that. And I caution students or nurse practitioners from working in fields and specialty populations where they're not educated and certified. For example, a healthcare system might hire a family nurse practitioner to work in the hospital, in the ICU as a nurse practitioner, but the education has not supported that. They're not educated in acute care. They're not educated in or received any clinical practice experience in that, and their certification is not in acute care. But that doesn't mean that hospital systems will not hire them into those positions because they don't fully understand. They think a nurse practitioner is a nurse practitioner.
Mm-hmm.
So that's complex. But yes, there are differences in the lifestyle and in the pay. The psychiatric mental health nurse practitioner, as far as all nurse practitioner populations, practices go, is the highest paid nurse practitioner It's because there's such a demand for that NP. And so that nurse practitioner, the median salary for a psychiatric mental health nurse practitioner is about $150,000 a year. Compared to family practice, the median's around $110,000. So that's quite a difference. Patient population is different. I think for some people, it's more taxing to diagnose and to help manage patients that have mental health disorders compared to physical acute disorders. I mean, it's much less taxing for a lot of nurses to treat an ear infection than it is to, to work with a patient that has bipolar and helping them understand the importance of taking medications, and just the sequelae of outcomes, when they do not. So it's a much more taxing role, but I know a lot of great psychiatric mental health nurse practitioners that are really good at what they do, and they love the role.
Okay. So now we know quite a bit about how to actually get into the program, the different types of nurse practitioners. I definitely want to know a little bit more about the different routes, because online it said there's the online nurse practitioner programs, there's the affordable online nurse practitioner programs, there's the RN to NP programs, BSN to NP programs, accelerated nurse practitioner programs, and the direct entry nurse practitioner programs. So some of these sound like the same. It sounds like BSN to NP programs is the same thing as RN to NP programs, because you have to write your bachelor's, you have to finish your bachelor's of science in nursing, and then you have to pass the NCLEX, become a registered nurse, and then enter into an NP program. And when they say NP program, they mean a master's in nursing.
Most generally, it could be a doctor of nursing practice program.
Oh, okay.
Yeah.
Doctor of nursing. So do you need to do a master's before entering doctor of nursing?
No, you do not.
So any RN can also apply for a doctor's in nursing.
It depends. So let me kind of explain it a way that might help your audience. There's two different types of program offerings and modalities. There's online and residential, right? So the majority of them are online now, and there are a lot of great residential and online programs. I'm not sure what it means to be an affordable online program. I mean, because really we have accrediting. I think that I'm not sure if that's just a marketing. I'm not sure. Because all of our programs, in order to be certified as a nurse practitioner, you have to go to an accredited program. There are two accrediting bodies generally that these certifying bodies. So when you're done with your NP program, you have to take an exam. It's a national certification exam. There's two companies that offer it. There's the American Nurses Credentialing Center, and then there's the American Academy of Nurse Practitioners. There's just two. Both of those, to sit for those and write those exams, you have to have graduated from an accredited nursing program. The accredited nursing programs look very, very similar in what they require in classes and practicum, because it is guided by the standards of nurse practitioner education. So they should all look very similar. It's how they're delivered online, a blend of online and on campus, or on campus. When I was in NP school, there was only residential. Now there are lots of online programs, and there's a wide variety and quality of online programs. Some online programs are very large and have not as good outcomes in student placement and student attrition, student national certification pass rates, and job placements. So I would encourage a student that's looking at an online program to look at the program's outcomes and how many students they enroll.
Where can we find this information?
So you can go to the Nurse Practitioner Association web pages. Offer a lot of guidance about what to look for in nurse practitioner programs. And I recommend that nurses or students call the program director. And if you get to talk to someone that can give you information, that's a good sign that they are, I think, invested in their program and that they have a quality program and that they are invested in the student. If you can't get anyone on the other side of the phone, and that's not a good sign. Also, because they aren't attentive, right? Unfortunately, we know there are what you've heard the term diploma mills, and it's not good for the student, and it's not good for the profession, and it's not good for the health outcomes of the nation. So I would caution students looking at online programs to make sure that it's a quality program based upon their outcomes. Students, how many students do they admit? How many complete the program? How many pass national certification? How many are placed? Or how many have jobs in 1 year?
Okay.
And also, what do those programs, the programs that have faculty and administration that care about student outcomes, they will care very much about the placement of students in practicum because they are responsible for that student's education. What does that program do to help secure a practicum placement, a preceptor for the student? Because in nursing schools have contracts with hospitals, long relationships where if a student doesn't have to worry about arranging that clinical experience. When you go to NP school, you hold a responsibility for your clinical practicum. So some schools fully place students, some schools work with students to place them with preceptors, and some of them do not assist at all. And
That's important.
It's extremely important because right now nurse practitioners are required to do 500 hours in practicum, and that number is going to go up in the next 10 years to 750. It's a big stressor for students. As a nurse practitioner faculty, program director, administrative dean for nursing online, it was something that was a topic of conversation every day, was placing students in practicum sites, because if a student has paid for a year of didactic education and then can't be placed in a site, they can't get a preceptor, they've wasted their time, their money, and it's extremely important. And so I would encourage nurses or students looking into programs to ask, what kind of preceptor placement support do you provide students in your program? And how many of your students are, do not complete a program because they couldn't find a practicum site. Practicum sites are difficult to get across the nation. There's not one school that doesn't struggle with it because there's only so many preceptors, okay? There's only so many healthcare providers, and they are taking students and precepting them, and it is very taxing to precept students. They don't oftentimes get paid to precept students. There are some preceptor placement companies that pay preceptors, but there is an ethical concern with that. They may have a very small stipend. So precepting a nurse practitioner student or other types of advanced practice students it slows down the healthcare provider. They can't see as many patients, and depending upon how they are paid, some of them are paid based upon the number of patients they see and revenue generated. That cuts then into not just their their day and taking care of their patients, but their patients then can be less satisfied because they have to wait a little longer than they're with the student, and also it can cut into their pay. So it's getting a practicum placement site is complex. So I encourage students to ask. Schools are looking at how do they support students in being placed in practicum, because it is a big portion.
That seems imperative.
It is absolutely imperative. Absolutely, yeah.
Well, that's very interesting because it sounds a lot like entry into the profession is difficult. So, for instance, in law, it's very similar. when we finish, we pass our bar exam, all that stuff, the first job that you get is very difficult to get. So, but you're saying that there's certain schools that really help with that, whereas there's other schools that don't. So you can get in touch with the faculty and ask them this stuff, and I'm guessing they'll give you a percentage,
Yes, they should be
right?
able to give you a percentage. Absolutely. They should be tracking those outcomes. If they're not, I would question that. As an administrator over an online nursing program, we had to seek approval in certain states to offer programs to students in that state. Louisiana is an example. And so when we went to before the Board of Nursing in Louisiana, we were had to provide that. They wanted to know that nurse practitioner programs providing services in their state to their residents were going to be able to place students in the state.
Yeah.
And also, how does that impact their programs, in their state? So we did provide those outcomes for them. So they should be tracking that outcome, and they should be able to provide that outcome. It's definitely. Now, what I will say is that it is not difficult for a nurse practitioner to get a job once they graduate and they are certified. There is a great demand for nurse practitioners. It's one of the going to be, even over the next 10 years, I believe the U.S. News and World Report said that they're going to need 118,000 there will be 118,000 new positions. So getting a job as a nurse practitioner is not as difficult, sounds like, as law, being an attorney, but getting the practicum hours while you're in school is extremely difficult to arrange.
Okay. Okay. So let's revise that because we talk about a lot of things.
Yes.
So, Bachelor's of Nursing, apply to nurse practitioner program. Year one, you study all the didactic, whatever the curriculum is, and then you want to go to an institution which has a high percentage of placing you in practice.
That's correct.
And then you finish that 1 year, and then you're a nurse practitioner.
Well, the master's programs are 2 years. So yeah, you usually have 1 year of population and practicum experience, and then once you meet the graduation requirements, you graduate. You have then your degree, your master's degree, and then you can sit or write the nurse practitioner certification.
Okay. And tell me a little bit about that exam.
That exam is offered again by two credentialing organizations, the ANCC and the AANP, and they are very similar in their exams. The majority of nurse practitioners take the AANP. Probably 65-70% of nurse practitioners take the AANP exam. It is considered to be a more practice-focused exam, whereas the ANCC exam has a more systems level research and for being able to evaluate research, which is an important skill for advanced practice. So ANCC, that exam tends to intimidate nurse practitioner students a little bit more than the AANP, but they're very similar otherwise. They are about 4 hours computer-based exam. They have about 150 questions on the exam. Students have to get, or graduates have to achieve about 350 out of 500 score on the exam to pass. As far as pass rates for the exam, both of them have historically, over the past decade, trended about 85% pass rate. However, the AANP, for some reason, dropped over the last year that was reported to about 75%.
Okay. And these are all multiple choice?
Multiple choice for the most part, point and click.
What's point and click?
Like you might have, there will be cases and you'll have to choose the best answer, but also there might be an image and you may have to identify anatomy or identify an abnormal lesion. For example, it might say which one of the lesions on the image is a basal cell carcinoma versus more concerning for malignant melanoma. And the nurse practitioner student might have to click or select the image on the screen for the lesion that looks like basal cell. That makes sense.
Yeah. Me no comprende.
Yes, but two different exams. Yeah. 85% pass rate, generally speaking, and 4 hours, 150 questions.
Okay, so We were discussing all the multiple routes. There's not many multiple routes. It's residential or online.
That's right.
All right. You
Delivery,
get
yep.
into a school, finish both years or part time, and then you write the exam. AANP is the more popular
Mhm.
route. And after that, you get what?
Well, you have to become licensed
Yeah.
in your state. So, nurse practitioners are nationally certified through those bodies, and then they have to apply for licensure. Every state has very similar requirements for nurse practitioner licensure, but there may be some caveats. And that is the other thing that I think is worth discussing it just a little bit is that online programs are not approved in every state. Remember, I said
Mm,
that we had to go to the before the board of Louisiana and request permission to offer the program in the state. And when we do that, we have to show that we're going to meet the state requirements. Generally speaking, the majority of the states are very similar in their requirements. There are a couple states that have specific requirements: New York and Louisiana, Oregon, Washington. There are a few states that are have special requirements that schools, quite frankly, don't care to meet. They just won't become approved in that state, and they don't accept students from that state. So, if you are looking at an online program, you want to make sure that the online program is approved to offer the program in the state that you want to be licensed in. Otherwise, you might graduate a program that there are additional requirements after you are certified and licensed. Like perhaps like New York requires that students take a pharmacology class specific to New York prescribing
mm,
laws. And so, if you don't take if you take a program that doesn't include that, then after you graduate, you're going to have to meet that requirement to be licensed in the state. So prospective students need to make sure that that program is approved in the state. They'll become nationally certified. They will apply for licensure in the state. They'll be state licensed. Nurse practitioner license is by state. There is no multi-state compact like there are for a lot of states are in a compact for registered nurse license. So meaning if I'm licensed in Virginia, I can practice in North Carolina, or if I have a multi-state license. Nurse practitioners do not have a multi-state compact at this point. There is a trend, hopefully, to move toward that. There are a couple states that do honor each other's nurse practitioner license, state license, but it's not robust at this point. So you want to you'll be licensed in the state that you want to practice in. If you're doing telehealth, that's a whole other story because you have to be licensed in every state that you provide telehealth services if that state requires it. Every state has has the ability to set their own requirements for the care of the residents in their population. So, but yes, you become licensed. There are other requirements that providers have beyond nurse practitioners have as providers beyond a registered nurse. Like we have to have what's called a national provider number. It's called the NPI. It's NPI number, and that is a number that is assigned nationally so that it's an identifier for billing purposes and for prescribing purposes. And also, prescribing any controlled substances requires a DEA registration. And then, oftentimes, first the practice will apply for those numbers, those registrations as part of the onboarding, part of the credentialing process. So they'll be the nurse practitioner when they accept a job, they will become credentialed. That's what we call it. They'll get an MPI, they'll get a DEA. They will be the organization will seek approval for that provider to bill insurances, Medicaid, Medicare, so their services to those payers, and they will also provide malpractice insurance. So they'll credential the provider. That process usually takes about 90 days to credential. Once they have their certification, they've signed a contract, which is another consideration that you might want to talk about later. Is there's nurse practitioners can be employed like a straight salary or hourly employee, or they can have a contract. And contracts look different based upon different organizations. Sometimes it's strictly salary. Sometimes it's salary plus they have to have a certain score on patient satisfaction. Or they don't get their bonus, so there's bonuses. Or if they don't meet a certain revenue, see a certain number of patients within a certain time frame, then they would not be eligible for a bonus. So there's lots of things to consider there. But yes, they graduate, they get their degree, they sit for national certification, they then apply for licensure, then they choose, they apply for the position that they want to move into practice, healthcare system. Healthcare system will work with them to credential them and get them through that 90 days of credentialing. Then they will start their first position. Yes.
Wow. There's a lot to becoming a nurse practitioner.
There is, but it's doable. Lots
how
of
long
us
does
know.
this take? So we have 4 years for becoming a nurse.
Yes.
Then you can directly apply, and then 2 years full time, so 6 years, and then you're a nurse practitioner.
Yes.
Right? And
yep.
You said 90 days for that entire process, so like 6 years and 3 months.
That's correct. Yeah.
And then that's pretty good. And you answered so many questions, by the way, along the way, so that's awesome. One thing that I'm interested in, I remember Dr. Akers was telling me that a lot of the hospitals or institutions that you work at will pay for your nursing degree. Mm-hmm. Is that the same thing with nurse practitioners?
Absolutely.
So if you're working at a hospital, they'll cover...
Absolutely. There's a lot of health systems that have desperate need for healthcare providers, with the most desperate need in primary care. And with the adult population, with growing population, aging population, essentially all healthcare systems have a desperate need for primary care providers. So that is their impetus to provide that benefit to their nurses. A lot of healthcare systems will include in their benefits tuition assistance, tuition reimbursement, for advanced practice, for the master's and nurse practitioners programs.
And how do you find out about who will compensate you and who won't?
Well, you need to talk to they need to talk to their human resources department. Okay. That's where the benefits come from. They'll be able to provide them how much will they reimburse, what is the commitment to the health system or practice once they reimburse. That's one mechanism for having education paid for. There are other grants and opportunities. For example, the Virginia Healthcare Foundation offers scholarships to nurse practitioners who want to become psychiatric mental health nurse practitioners. They will pay for the program in its entirety.
Wow.
So looking at those foundations, and then there's also several national health corps foundations that if a nurse wants to go into advanced practice and will agree to work in an underserved area, they will pay for their, they will forgive or reimburse their loans up to a certain percentage. And there's several of them. But the commitment is that they have to commit to work in those underserved areas for a designated period of time, whether it be 3 years, 5 years.
Yeah, but essentially when you're a nurse, go to your institution,
Go
find
to your
out,
institution, yes.
and press HR and find out what you're eligible for.
That's exactly right, yes.
That is cool because not a lot of professions have that.
No.
So nursing has that, and obviously nursing practitioners get that as well. So that's really cool because, I mean, they say the average debt is somewhere in excess of $200,000. So, I mean, especially if you're going for an advanced program.
Exactly.
So to walk out with no debt, that helps a lot because, I mean, you're basically starting your life and the money that you earn is going towards your life rather than student debt and all these other things. Absolutely. So that is another cool thing. So now I want to know, we were talking earlier, let's first discuss, what does a nurse practitioner do? And since you're an FNP, a family nurse practitioner, what does a family nurse practitioner do? And where do they work typically?
So family nurse practitioners work in a lot of different settings, but they're educated, trained, certified to provide primary care in the outpatient clinic. So in physician offices, medical clinics, urgent cares. So they have a panel of patients. They can either have their own panel of patients, or they can work collaboratively with physicians to help take care of the patients of that practice. So when I was in family practice, there were patients that were my panel of patients. So they were assigned to me. I was their assigned primary care provider.
So it's like the same as a family doctor almost.
That's exactly right. It is very much the same. There's a shortage of family physicians, and that has been the impetus for the demand for nurse practitioners in primary care. It is very much like a family doctor. So every state, like I said, has different practice acts and standards and scope of practice for practitioners. Some of them are very strict, and that a nurse practitioner cannot be the primary care provider or bill, which if they can't bill, they can't really be a primary care provider. They can't bill independently based upon the state regulations, their state licensure. Their license doesn't allow them to be the primary care provider of the patient. And then other states are very independent. So, for example, I've had the opportunity to work in several states as a nurse practitioner. My husband was in the military, so I graduated in Ohio. Ohio would be considered, they have a moderate amount of autonomy in Ohio, nurse practitioners do. That's where I was educated. And then when my first position as a nurse practitioner in family practice was in Iowa, where I was completely independent, and there was no requirement for any agreement between me and the physician. So in Ohio and some other states, there are requirements for the nurse practitioner to have a practice agreement with a physician, with a medical doctor or a DO. Other states do not require that at all.
What's a DO?
A doctor of osteopathic medicine.
Okay.
Yeah. So it depends upon the state that they're in, to what degree of autonomy of practice that they have, and also what that healthcare system and or practice desires as their care model. It's great to work collaboratively with physicians and MDs or DOs and PAs. It's just some areas need more primary care providers. So it's important that a nurse practitioner be able to practice as autonomously as possible in order to provide care. So family nurse practitioners provide acute, and when I say acute, I mean self-limited care of problems such as like ear infections, urinary tract infections. Very limited, there's an illness and then there's a treatment and the patient gets better. Very acute self-limited diseases, and also chronic diseases, asthma, COPD, heart disease, chronic musculoskeletal diseases, a thyroid disease, diabetes, things like that. And then there's the well care that goes along with taking care of a patient. So a family nurse practitioner, in their perfect family nurse practitioner role, cares for patients across their lifespan and takes care of their primary healthcare needs, like a family physician. They do their well visits, immunizations, they see them when they're sick. If they have something more chronic, they can assess, diagnose, order diagnostic exams, tests, labs, x-rays, scans, physiological tests to make a diagnosis, and then manage the disease.
And prescribe.
And that means prescribe medicines, prescribe physical therapy, prescribe other cardiac rehab, palliative care, hospice care. They prescribe what the patient needs to manage the disease. So yes, across the lifespan, ideally everything that the patient needs that they can get from them outside of the hospital. Now those patients do, go to the hospital, and family nurse practitioners generally, in the most part, do not have an outpatient and an inpatient practice.
Can you tell me a little bit what's outpatient, what's inpatient?
So outpatient means in the clinic, things that you can do in the community. You know, with patient comes to the clinic, you see the patient, you assess, you diagnose the patient, treat the patient. It's all, and the patient's not admitted to the hospital for nursing care or medical care. Inpatient is where the patient is acutely ill or needs care that can only be provided in the hospital.
Okay.
They need 24-hour care for a while, and more advanced care than you can get in the clinic. Okay, so a lot of family nurse practitioners, they work only in the clinic, in the outpatient setting, taking care of acute chronic diseases, well child exams, immunization, sports physicals, Department of Transportation physicals, those types of things. That's the day-to-day patient, what that looks like for them. Nurse practitioners generally see in the outpatient setting about 3 patients an hour. So 20 minutes per patient. Some patients have more complex problems. It takes a little longer. Some are more simple and, much more simple and less time intensive. So, but on average, 3 patients an hour. So in an 8-hour day, you're going to see approximately 24 patients during the day that come in for appointments, and the patient is brought in to see the healthcare provider and into an office space, into an exam room, and whenever the nurse practitioner first looks at their schedule and they're okay, here I've got Mr. Jones who's coming to see me today, and he's coming to see me because he has shortness of breath. And the first thing that I would do as a nurse practitioner would be look up and review his medical records, what's been going on, gather what information I can from that medical record to understand what's going on with Mr. Jones before I go in and talk with Mr. Jones. And then when I go in and see Mr. Jones, we're going to have a conversation, and I'm going to listen to him about what's been going on, what has he experienced that brought him in to seek care that day, and understanding the trajectory of that symptom or illness. And then you do physical exam, an advanced physical exam, more than what a registered nurse in the hospital may do, more specialized exams, looking in ears, possibly doing a pelvic exam or other type of special, more advanced exams, whatever the patient needs, whatever you need to help inform your diagnosis or to make the diagnosis. And diagnosis meaning a medical diagnosis. So Dr. Akers talked a little bit about what a nursing diagnosis is, how it's the patient's response to an illness, whereas nurse practitioners make medical diagnoses. So they have a patient, Mr. Jones comes in and he tells me he has shortness of breath, and he's had shortness of breath for a week, and he's had a cough, and it's been productive, and I find out all of those symptoms and those associated factors related to that symptom, and I do a physical exam, and if his lungs are clear, that means something different than if his lungs have congestion in them. And so based upon the history, the physical exam, diagnostic test, maybe Mr. Jones, I hear lots of congestion in his right lower lobe, and I confirm that he has pneumonia with a chest x-ray. And so we'll have him go get a chest x-ray and make a diagnosis of pneumonia, of right lower lobe pneumonia, and then prescribe the appropriate medications, antibiotics, inhalers, and then make sure that he has a follow-up to make sure that his illness has improved and resolved completely. So that's what that might look like for that patient that has a symptom.
That's pretty amazing. So
yeah.
it sounds like the role of a nurse practitioner is significantly closer to that of a doctor rather than a nurse.
Absolutely, to a physician rather than a nurse.
I mean, every nurse practitioner is a doctor.
No.
No?
No.
So who gets the DR?
So a doctor is an academic degree.
Okay.
So a medical doctor has a doctorate in medicine. A doctor, and that's a whole other topic, but I won't get into some of that. But doctor is a title based upon an academic degree. Though in healthcare, we call doctors that are we consider them, they're physicians. That's who we consider as doctors in the healthcare system. But in academia, they can have a doctorate in psychology, in education, and that person has the title doctor because that's the degree title. But in healthcare, nurse practitioners can have a doctorate, and many do, but do they or do they not go by doctor? They do not make any, there should never be any confusion that a patient is seeing a nurse practitioner versus a physician. And that is often, that's an ethical, professional issue, clearly, for a nurse practitioner. They don't want to be misrepresenting themselves as a physician or a medical doctor.
That's where my head was going.
That's right, absolutely.
Professional responsibility.
No, absolutely. And nurse practitioners have a different approach to patient care. We value relationship with our physician partners, and there's a definite role that I see for both, even though nurse practitioners are doing a lot of primary care. There's still a demand and great need for them for both roles and for them to collaborate. But absolutely, a nurse practitioner, even if they have a doctorate degree, even if they call themselves Dr. Murphy, I would say, I'm Dottie Murphy, I am a nurse practitioner. Some states do not allow nurse practitioners, or healthcare systems, some states or healthcare systems do not allow nurse practitioners to introduce themselves with the title doctor because they do not want patients confused. And that's understandable.
I was working on a lawsuit.
Yes.
And in that lawsuit, that was an issue.
Yes, it is an issue. And no nurse practitioner should want their patient to be confused about their role or their credentials. And so many states and many healthcare organizations say they will say that you are not allowed to identify yourself as Dr. Murphy in our health system. Some do, and some do, and some don't have any other requirements, and some do and say it's okay if you call yourself Dr. Murphy, but you need to still make sure that the patient knows you are a nurse practitioner.
That's exactly what I was going to ask.
That's right. So
So it is appropriate to say, hello, I am Dr. Murphy, a nurse practitioner.
In some states and in some healthcare institutions, they will permit that. I personally,
What's the best practice?
I don't hold anything against someone that chooses to do that. It's not for me. I never want to be in a position where my patient is confused, and that patients, when they hear doctor, they think it's a medical doctor, and I don't want my patients. I want there to be a good relationship that's based upon trust, and I never want them to be confused. And so I don't introduce myself to my patients as Dr. Murphy. I introduce myself as Dottie Murphy. I'm a nurse practitioner. And but there are nurse practitioners in our health system that do have that do identify themselves as Dr. So-and-so, but they still do say I'm a nurse practitioner. I just think the more transparency and the less opportunity for confusion, because patients don't always hear that you just said, I'm Dr. Murphy, I'm a nurse practitioner. They stopped listening after Murphy. They heard Dr. Murphy, and that's it. So I don't ever want there to be any confusion, ever. So.
That sounds good, because in that lawsuit, I remember that was actually an issue. And I remember in the briefs that I was reading, that was actually the reasoning, because they presented themselves as a doctor. They did also indicate they were a nurse practitioner, but the client did not hear. I mean, the patient didn't hear.
Yeah.
But okay, so you get the doctor credentials if you take a doctorate in nursing.
That's correct. So, so the majority of programs in the United States have been a master's program. Like I said, there is a transition to being more of the nurse practitioner programs being offered at the doctoral level, not the master's level. If they have a doctorate in nursing, it supersedes the master's in nursing. They can get certified license just like they would if they had a master's degree. But they have gone into a doctoral program. So there's two ways. If you have a master's degree, let me step back a little bit. If you have a bachelor's degree and you want to become a nurse practitioner and either you can go to a master's program or you can go to a doctoral program. Okay, a master's program is 2 years, a doctoral program is 3 years. If you have a master's program, you can do a postmaster's doctoral program. So if you are working and you want to work and you have a family and you want to pursue your doctoral degree, you can do that after you've completed your master's degree.
And that's just 1 year.
The master's degree is 2 years.
Yeah, but the doctoral part.
The additional doctoral degree can be 1 year full time. It's a very rigorous full time. Most people do it in 2 years.
Okay.
And the doctoral degree is the Doctorate of Nursing Practice is based upon educational standards of what does it take to improve the health of the nation and a population at the systems level. So it's going to be more research, more theory, more get into intercollaborative care among professionals.
It's like global oversight almost.
It's like, yes, exactly.
So do these people go into government and
some of them do. There's leadership, you learning about healthcare operations. So that year after the master's, or if they do the DNP, that will include, it's called systems leadership. And that's where the focus is, so that you can be a leader in the healthcare system. You've got a foundation of practice and patient care, understand a population, and then you can understand how to improve the health outcomes of a population of patients, not just one patient or your panel of patients. So you might be designing systems and practices or healthcare systems that improve patient care. The reason one of my acquaintances said, "Why does there need to be a doctor in nursing? I mean, can't you just be a nurse?" And the answer was the most striking answer for that is that research and evidence is generated, and it takes 20 years historically for that new knowledge to make it to the bedside. One of the things that the Doctor of Nursing Practice does is you become ingrained in looking at evidence and applying it to systems. So instead of it taking 20 years for new knowledge to impact patient care, it can get there in 2 years. So that is the goal. The goal is to raise the level of education of nurses so that they can take knowledge from not just like general knowledge from research, but also systems knowledge, operations knowledge, and apply that to patient care and patient care systems in order to improve the outcomes of populations.
Okay, so it seems like the doctorate program is very overarching.
Yes.
Right? So do these doctors actually go into practice at all? Or they don't seem to be barred, right? It just seems to be a different route altogether.
It is. It's a different route. So they can either go in and get a master's degree and then do the extra degree, the postmaster's doctoral degree, or they can go into a post-BSN, meaning they have a BSN degree, and through that degree, through approximately 3 years full-time degree, they can get a doctoral degree and their training as a nurse practitioner.
Okay, do they get paid more if they're doctorate versus master's?
At this point, we don't see a pay differential between the master's and the doctoral degree. Now, that doesn't mean that there are other opportunities for leadership, which tend to have higher pay positions. You can teach with a doctoral degree. You're more credentialed for consulting, legal consulting, program consulting, health system consulting. So there's a benefit, but in the straight pay, a nurse practitioner that graduates, a family nurse practitioner that graduates with a master's degree, and the salary of a family nurse practitioner that graduates with a doctoral degree, there's no significant difference at this point in time, but it opens up a lot of opportunities, and it allows you to have a more robust practice, I believe, having had both.
So do you think that if you were to go to HR in your institution, do you think doctoral programs are covered less, or are they promoting that just as much?
They'll cover them
Okay.
just as much.
I
From what
thought that, because it seems like more
it, it,
leadership oriented, so
it
there would be
is,
less
yeah.
coverage.
You're right, but
Because
the
there's
national
technically shouldn't be as great of a demand for leadership positions, because there's probably a lot less of them required in
right,
comparison
right.
to the, nurse practitioner and the other four areas that you talked about.
Exactly, and there is not as great of a demand in maybe systems level leadership at a large healthcare institution level. However, every clinic needs practice leaders, and they need people in the practice who are changing and keeping their practice up to date with the current standards of care, the newest evidence, and making sure that that practice, even at the community level, is doing that. And that's what I believe the DMP allows them to do, whether it be at the micro or the macro.
Medical consulting.
That's right, yes.
That's awesome.
So, yeah, it's great. So, but it's, like I said, the goal is ideally that nurse practitioners would be educated at the doctoral level, but we're not there yet. And we need primary care providers. And so I don't see that going away. I got my master's and then did a DMP program because when I was around 35, because I thought I'm going to be working for 20 more years, and new nurse practitioners are going to be coming out of school with a doctorate. And what does that mean for the rest of my career trajectory? Am I going to be able to bill? Will they change the billing scheme? Because currently nurse practitioners, when they bill Medicaid, Medicare insurances, they are reimbursed at 85% of the physician rate. So if a physician bills $100, they get $100. If a nurse practitioner bills for the same exact services and they bill that code, they get $85. So, but that's been going on for, that's ancient. And it doesn't really reflect what's happening in the healthcare system right now. And I think that will change eventually, but it hasn't yet. But that was a consideration I had, as a nurse practitioner that had a master's degree, and that was one of the impetus for me to go to get my doctorate when I did.
So thank you for that. In the beginning, when I drafted these questions, I was really interested in knowing the difference between a registered nurse and a nurse practitioner, but they're completely different roles for the most part.
Yeah.
I am interested in knowing in most states, what can a nurse practitioner not do that a physician can do?
Well, it depends on what type of physician.
So family. So family, like let's compare an FNP to a family doctor.
A family in highly autonomous states, a family nurse practitioner can do exactly the same thing that a family medical doctor can do. Now,
do you think in patient outcomes you have seen any difference in the outcomes from services rendered by a nurse practitioner versus a doctor?
There were a lot of outcomes, and there were a lot of studies and outcomes that were done in my lifetime before my entry into advanced practice on the outcomes of nurse practitioners versus family physicians, and the outcomes were comparable, in some areas better. Patient satisfaction was much better with nurse practitioners. Nurses, like I said, they've long been the most trusted profession in the United States. They seek to establish strong rapport with patients. They see them holistically, and that's not to say that physicians do not. It's just that's where their focus is.
Yeah.
Their focus isn't on diseases, but it's on how can I help the patient manage a disease. And family physicians do that extremely well too. I'm not saying that they don't, but that is an area I think where nurses have been able to establish that rapport differently than what historically medicine tended to be, a little more paternalistic in that this is the disease and this is the medicine you're going to take.
Yeah.
And then patients leaving with a pill bottle and throwing it in the trash on their way out, because it's that was the trend. I think that healthcare in general is moving away from that trend and realizing that. But
Can you tell me the trend again? Like, are you saying that the trend
the
is
trend,
that doctors are paternalistic and they just tell you what to do?
no, I think that historically I'm not saying that all of them. Please,
Oh, no,
yeah, yeah,
definitely
no,
not.
not all of them. But I think historically patients physicians have been more paternalistic in that directive of care decades ago, many decades ago, and whereas nurses have always been on the front lines and trying to work with the patient and collaborate with them in order to motivate them to do what is best for their health outcomes, and seeing them more holistically, understanding, that they have a dog at home and that's why they don't want to go into the hospital,
Yeah.
or they're taking care of someone, or they don't have transportation. Those are the things. And I do think that is going away as far as that trend of paternalistic medicine. I work with great physicians who totally understand and treat patients holistically, and understand the complexities that become barriers to patients having good health outcomes. So I think that trend is going away in healthcare, and that there's a absolutely paternalistic care, interactions with patients. Yes.
I'm not trying to disparage anyone.
No.
I just it makes sense why the patient outcomes are a bit more positive with respect to nurse
Rapport. Yeah.
practitioners, because I was recently at a hospital, and I've been many times, and I was talking to Dr. Akers about this, and empathy happens to just be a very prevalent
Mm-hmm.
emotion or characteristic that you do note
Mm-hmm.
amongst nurses.
Yeah.
Now, if these nurses already have that the ability to empathize, and then they actually get higher education, then it would make sense why they can build rapport better,
Yeah.
right? So it makes sense. I completely understand what you mean by not disparaging any of the doctors.
That's
Of
right.
course, I completely understand that. And okay, that's cool.
Now, health outcomes, there are studies that say they are comparable as well. Health outcomes such as, for example, a patient that has diabetes and their blood sugar control. So there are studies that show that they have compared different roles, physicians and nurse practitioners, and those studies were done early on because their nurse practitioners did not have authority, and they were demonstrating that advanced practice nurse practitioners could help patients achieve those outcomes. And so those studies were done to demonstrate that, and were useful in helping to change state practice laws, so that nurse practitioners could provide the care. So things like diabetes outcome, high blood pressure outcomes. These are common diseases in our population, and there's not enough medical doctors to take care of them. And there is a science, and there's anatomy and physiology and pharmacology behind those treatments, but they're so common that we have to be able to have nurse practitioners to fill the need for those common diseases. And this, and another example in advanced practice and the relationship between advanced practice and physicians, is midwives. Midwives have been around for centuries, for thousands of years. Midwives have been around, and so have physicians. And midwives have been the primary deliverer of babies around the world for centuries. And then physicians are trained in a much deeper medical science than nurses are, and the midwife would take, even still today, will take care of a laboring mom, and if there is a complication that is beyond the scope and the training of the midwife, then they will call the patient will then be transferred to the care of the physician. And that's been going on for centuries. So very similar, I would say, in family practice, is where there are very common disorders, diseases, processes that we can help patients achieve health outcomes for. And if there's something that's a zebra as far as a diagnosis, or a very complex situation, where their expertise is absolutely necessary in helping to care for the patient. I think there's a good role for that. And physicians are also, you know, they also trailblaze new medical technologies, new medical pharmacologies, things like that based upon their training, new diagnostic techniques, and it's really helped expand. So, but apples to apples, the day-to-day care of a patient panel in primary care looks almost identical, if not identical. When I was in primary care, the physician I worked with delivered babies. That's one thing I did not do. And a lot of primary care providers decades ago did deliver babies. So that's one thing he did that I didn't do. In general primary care these days, we don't see primary care physicians delivering many babies. So they do get a lot more training in their medical training on procedures, outpatient procedures, and that's really program dependent. And it's not that the family nurse practitioner can't do those procedures, it's that they have to seek and training and become competent in the procedures. My nurse practitioner program did not have any training in suturing at all. So coming out of FNP school, I was not as competent in suturing as my physician counterpart. I had to seek the training and under truly collaborated with them in the practice to become competent in that. So training plus experience equals competence. So, and there are other, like I didn't learn how to remove toenails for someone that had an ingrown toenail, so definitely physicians in their medical training get that training. Now, more and more nurse practitioner programs are providing that training. Like the nurse practitioner programs I have taught in and overseen, they include that training because it's part of primary care. But back in my day, we did not have that training like physicians did. But now we're seeing a lot more of that practice looking very similar.
Okay. Well, it seems like the gap is very, very small based on everything that you just told me. So common diseases, because I'm trying to just draw the distinction between a physician and a nurse practitioner. And like you said, it seems to be very slim.
In practice,
Yeah.
education's totally different.
Yeah, in practice. That makes sense. Okay. Awesome. I feel like we have a pretty good idea of how to become a nurse practitioner, the many different routes, what you actually do on a day-to-day. So, and your role is a lot closer to that of a physician than that of a registered nurse. So I'd like to move on now and discuss, to become a successful nurse practitioner, what kind of characteristics do you need? And I want to be specific to family nurse practitioner.
Okay. Yeah, definitely the empathy and the ability to establish rapport, to partner with patients so that they can achieve their health goals. I mean, that's fundamental. And of course, equally fundamental is the ability to critically think. And in practice, we call that clinical reasoning, to put the clinical picture together of what the patient's telling you they feel and have experienced and what you see objectively, to make a diagnosis and to clinically reason to prescribe the management they need that they will adhere to, that is good for them, that's best for them, and that will achieve the health outcome. So definitely empathy, building rapport, communication, critical thinking are definitely
Guessing teamwork as well, because you have to collaborate with all the physicians.
Absolutely. And some more than others in some practices. Yeah, absolutely teamwork. I think, Dr. Akers talked a lot about teamwork for the nurse and the acute care bedside. And there is more independence and autonomy as a family nurse practitioner so teamwork less, but yes, definitely still very important. Absolutely.
Okay. So we got empathy, we got the ability to build rapport, great communication skills, and critical reasoning.
Clinical reasoning. Yeah. Critical thinking,
clinical reasoning.
Yes.
Oh, okay.
That's right. Yeah.
Awesome. Now, what type of person would not enjoy becoming a nurse practitioner?
I think that the person has to they have to like people, and they have to be a people person. They have to they don't have to like people to be around them all the time, but they have to have a genuine interest in the well-being of people and want to help them to achieve their health goals. The person that may not be is the person that doesn't really care to engage or help other people. I don't find that many people would say that they don't want to help people or care to help people. And some people have an interest in health and medicine. And I think that's definitely from the time I was 8 years old, I was reading my mom's nursing textbooks, so I definitely had an interest in health and wellness. But who do I see struggle with the role are those that don't really they're not in the profession because they want to help people with their health outcomes. They're in it for another reason, either because, it's considered the number one ranked best job in the United States, or it's the number 23 best paid job, or it's 9 to 5 and no holidays and weekends. Like there's some other reason that they're in the profession. But again, I say the people I'm around nurses all the time in healthcare. So 99% of the population I'm around love to help people, So from that perspective, the people that I see not do well from the healthcare arena are people that are insecure. Because you do have to be skilled, have good critical thinking, and you have to develop a confidence in your ability. And you have to have that confidence has to be seen by the patient in order for them to trust you. And if you do not have confidence, then you will always be second guessing your ability and you become ineffective. And on the other end of that, insecurity can manifest as arrogance. And patients do not want to be around an arrogant nurse that's insecure. And so, I think insecurity is hard to overcome if someone's insecure, and be in the profession. Not that they can't, but I've seen real objective outcomes among student populations where they have been insecure and not been successful in their educational pursuits or their practice. There's data that that I've seen that helps me see that. And it's not that you don't go from being a novice to an expert. And we all walk into the profession sometimes not knowing what we don't know, and not being an expert and being new and building that experience. It's not that kind of insecurity. It's a deeper insecurity, I think, that some people can't overcome.
Well, they need to go to a psychiatric nurse practitioner.
Maybe. But I remember, and as a new nurse practitioner, we had a little discussion about the first 5 years of being an attorney. Well, the first 5 years of being a nurse practitioner is hard as well. And it feels like you do not know anything. Like you just graduated a program and you go into practice and nothing is textbook. And you can't just be a paternalistic provider. You have to figure out how to coach patients into achieving their health outcomes. So you feel like you are drowning for absolutely the first year. And oftentimes, it's 3 years before you feel like you have some bearing. I believe in family practice, especially because you are responsible for all body systems and, such a broad basic care that you have to provide. But I remember one time I asked a family physician I worked with in my first position in family practice, and I was like, how am I ever going to learn this? And he said, my dear, that's why they call it the practice. And I was like, oh, so I'm not going to be an expert when I walk out of school.
So for all the viewers, we got cut off because one of my cameras started malfunctioning. So my apologies. So we were discussing what characteristics should avoid becoming a nurse practitioner. And you had mentioned, I'm just summarizing, but it was someone who's disingenuous or not joining the profession
Mhm.
for the right reasons.
Mhm.
Somebody that lacks confidence, somebody that can't communicate well. What else?
There probably is a personality type. I just don't know exactly what type it is. Because what's funny is there my husband is a military officer, very blunt and maybe more paternalistic. He might approach people and he's very business minded, very analytical and very business minded. And it's not that those types of people, he actually considered being a nurse practitioner one time. And I was like, no, that would not be good. You would not be able to establish rapport with a patient and get them to achieve. But actually, he is so blunt that there are a good amount of patients that would very much respond to that straightforward, this is how it is, and this is what you need to do. And there's no sugarcoating it, and you can't sugarcoat things sometimes. You inform patients about what's going on, and if they can't hear you, you have to be extremely transparent and blunt. So, but back then I said, I don't know that you would really be a good nurse practitioner with this, but to be very honest, that person learns how to engage and patients, and they learn the profession, and then there's other opportunities that their skill set is better suited for. So even whenever someone has a personality that might be more analytical or more business driven, more minded, more abrupt in their communication, I have still worked with physicians who do similar, engagements with patients, and other nurse practitioners, physician assistants that have more of that, what might seem not that empathetic personality, who have had great outcomes with patients and have contributed greatly to health systems in improving health outcomes. I think it would be hard to be a comedian and be a healthcare provider unless you're Patch Adams, right? And you could balance that somehow. But anyway, there's a lot of good personalities. I think there's a lot of opportunity for all types of personalities in healthcare. But I think that you would have to have a desire to help patients.
That
Number one.
seems like the main one.
Yeah.
Okay, so nurse practitioner is ranked as the #1 profession in the United States. Is it stressful?
It is stressful. And
So it's a two-part question then. Why is it ranked #1?
I think it's a balance. So the rankings look at lots of things, right? They look at the enjoyment of the job. And so what do I enjoy about being a nurse practitioner is there's a lot of enjoyment in helping other people and with things that they can't help themselves with, or help their families can't help them. There's satisfaction in helping people. It's a good compared to the swing shifts of being a bedside nurse or working 30 hours as a hospitalist physician. There's a lot better work-life balance, and the pay is sustainable. I mean, it may only rank as the 23rd in pay in the United States, but it's a good pay. So I think those are the three things. And again, there's the opportunity, there's flexibility in the career path. As a family nurse or as a nurse practitioner, you can work, there's opportunities in outpatient, there's inpatient, there's opportunities to learn and growth. So in general, the U.S. News and World Report, they look at many different attributes of a job, and that means satisfaction in the actual work, opportunity for growth, pay, flexibility, all of those things, and they score that. And the nurse practitioner role scored at like 7.4 or 7.5 out of 10. And it has historically scored as the #1 for many years. And I think it's for those reasons. Those are the main reasons.
So
There's autonomy too.
Mhm.
That nurses, I feel like there's that you may not feel like you have as a nurse, that you are able to make a bigger impact with more autonomy as a nurse practitioner.
Okay, so did say that there was stress.
Yes.
So is the stress the 8 hours that you're there?
The stress, the
What makes the profession of a nursing practitioner stressful?
there are two different types of stress. There's administrative stress, and I think that all nurse practitioners would say the stress that they feel is that they are in their job to help take care of patients, and then they want to their heart and their desire is to be with the patient and take care of the patient, and then there's the administrative stress of all the documentation that comes with it. So I think that nurse practitioners and physician assistants alike would all say that the documentation is the administrative piece of that is the most stressful. That's one stress. And why is that? Because if I see 3 patients an hour, 24 patients in a day, I have to keep up with the charting on that. And if I see a patient right now, I might spend, if I have 20 minutes allotted to see for that patient care and documentation, I might only spend 5 minutes with the patient. And there's been maybe 5 minutes, 3 to 5 minutes of reviewing the chart before I go in to see the patient real quickly. I go in, I'm trying to give the patient what they need. And sometimes I only have 5 minutes, and then I have 10 minutes of charting. Well, we're there to serve, to take care of the patient. So we're going to spend as much time with the patient as we can and figuring out what they need and managing their care. And so the charting ends up happening at the end of the day. So the stress comes from, seeing patients for 8 hours and then having 2 to 3 hours of charting if you don't manage well. So you have to learn how to balance your patient load, manage your time. You have to become a skilled interviewer and get, what you need and guide the encounter with the patient so that you have enough time to manage and take good care of them, but also not work 16 hours a day because you've got, 4 hours of charting. So that's one stress. The other type of stress there is the stress of knowing that the decisions you make, the risks that are associated with it. And I'm not sure if everyone feels that stress, but that's a stress that I feel. If I give a patient a medication, every medication has a potential risk, a risk of that's deadly risk versus, you know, a less risky risk, I should say. But there's always a risk anytime you do something. Any intervention with a patient, there's a risk. There's a risk that's associated with certain tests, with medications, and that is you can't help but think about that, and when I leave the clinic at the end of the day, how did Mr. Jones do with that medicine? Did they take the medicine? Did that, I work now in cardiology, so I work in a CHF clinic, and how are their kidneys responding to that medicine? So there's all of this, theoretically and experientially what usually happens, but you still bear that concern for the patient. So those are the two, I think, the stressful pieces of it is there is a demand to see a certain number of patients. A lot of nurse practitioners have that demand to see a certain number of patients within a certain period of time, and then they don't have time to do their charting. But I think that
Why not chart concurrently? Does that have an impact on how many hours you're available for? Because the office is...
Some providers do take a computer into the room and they chart while they're talking to a patient. That interferes with your relationship and your encounter with the patient when you're looking at a computer and typing and trying to multitask. I think that's one thing. Though a lot of providers do try to do that. That's an interesting area where AI is actually maybe beneficial in the healthcare field, where their AI is interprets the interaction with a healthcare provider and the patient and then documents the encounter. And so that would be one area where AI might improve the healthcare provider burnout, their job satisfaction. But there is stress. It is considered a high stressful job, and I think it's because of that, the documentation and the risk associated with prescribing treatments.
Okay, now how many hours? I thought it was 9 to 5, but you said that you also have to spend time charting after. So on average, how many hours do you think somebody starting off in their first 5 years would spend? Because I'm guessing you would become more and more efficient and you would
Yeah.
just learn techniques to, work less.
That's right. You do. I think it's always going to take longer the first time you do it. And so the first year, you're going to work a lot longer hours. But I shouldn't say that because actually, when you first start off, your patient panel is you're not going to see as
Smaller.
many patients, right? And for the like when I was in family practice, the first 3 months, I instead of seeing 24 patients a day, I saw 12 patients a day. And then I gradually built up. And so that I could manage. So that way I wasn't ending the day with, 24 charts. Because if you get behind on charting, you've got 24 charts. And then if you're distracted trying to do it, so it could take you a long time to finish up charts. So the goal practices are very accommodating and allowing new providers to build up their patient panel and how many patients they see. So that's not uncommon.
Without affecting their salary?
Without affecting their salary.
Okay.
Exactly. Now, that doesn't mean if some practices do incentives based upon productivity bonus, then that could come into play. But for the most part, I've seen practices very accommodating for new providers in coming in and building up their patient load that they would see in a day, and so that they can accomplish their charting. There have been times I have been in positions where that wasn't possible, and I did see 30 plus patients a day and then had charting. And, that the practices were still looking for ways to minimize that burden. And that was before electronic records, and we dictated, and dictating was much more efficient than electronic medical records. Really added to the stress of documentation because we could dictate and get a dictation done in 2 minutes. But if you have to go through an EMR and copy and paste and go from page to page to page, sometimes I can spend 20 minutes trying to put a note together based upon pulling records from other pieces of the EMR. EMR, is ultimately will be beneficial. Some EMR systems are not near user friendly as others. So it varies. But yeah, there's a way to accommodate for that, and there are different.
But in terms of like how many hours, like how many do you think juniors start with? So let's say they have 12 patients, right?
They're
And
still going to see patients during the clinic operating hours. That's what they're going to see the patients because that's when the clinic is open and when they have nursing staff and administrative staff to help process patients through the clinic for the day. So they're still going to see patients from 9 a.m. to 5 p.m. and they're going to have an hour lunch break. The number of patients will change throughout the day as they become more experienced and can handle a heavier patient load. The goal would be for them to not have any more than 1 hour extra of documentation at the end of the day, though that's not always the case. Sometimes it truly is. It depends upon the practice. It depends upon the efficiencies of the practice, and that's something that they should ask about, with first jobs. How many patients am I expected to see in the beginning? How many am I expected to see, a year from now? How much what's the flow of the patient schedule look like? Because if you give me a full load of patients that day that have been in the hospital last week, that's going to be very different than 24. I couldn't manage 24 patients a day that had just been in the hospital last week with heart failure. But if I see 24 patients that have ear infections, UTIs, things like that are more acute self-limited, then I can see more patients. So what does that look like for the practice? And what is the expectation? I've been in practices where I've seen 30, 35 patients a day, and I've been done dictating at the end of the day and walked out, no, either on time or, no more than a half hour later. And then I've been in other practices where with EMR, and I've seen 20 patients a day, and I still have 3 hours of charting at the end of the day.
what's the average?
I would say probably 10 hours a day.
Okay.
And some clinics actually a full time is 4 days a week, and you really are only seeing patients. Your schedule is set to see patients for 8 hours, and then you've got 2 hours allowed for charting. So it does vary, but I would say 10 hours a day, 4 days a week would be very common.
Okay.
Or 8 hours a day, 5 days a week. And then you do learn how to you 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 learn how to survive in charting, and you learn the EMR does help in certain ways. You learn quick text and things like that that
Makes
help you.
sense.
Yeah.
Yeah. That's why I thought it would get faster over time.
It does get faster
Right.
over time. Yeah.
Yeah. But in the beginning, that's why I wanted to know what
Yeah.
should they expect, right? And you have energy when you start off,
But-
right? I mean, you're young.
Yeah, I don't know
So-
about that. You feel a little overwhelmed in the patients, but yeah, you do have a lot more energy. That's for sure.
Yeah. I mean, it's just all relative, right? So, okay. Number one career in America, you said the median income was $110,000.
Anywhere for family practice, 110 to 120 is what's reported as the mean.
Is that what as the mean?
As the mean, yes.
So what do they start off as?
Well, that's the mean for all nurse practitioners.
Oh, okay.
Now, that could be some nurse practitioners might start off at 110 or 120 in family practice if the practice has a high demand and they need a
Okay.
provider.
So you negotiate these contracts?
You can negotiate, yes.
Okay.
A lot of it depends upon the practice. Some practices might they might have many other benefits, and they start their new providers off at 90,000. So at the 10th percentile, you might see a nurse practitioner make 88,000 a year. 10th percentile. Mean 110 to 120. At the 50th percentile, 75th percentile is around 138,000.
So as the years progress, is there a ceiling that you've seen? Or because in a lot of jobs, what people do is they hop from one job to another job to another job, and those hops translate typically into more money. Is that how it is in nurse practicing?
I haven't seen that as much.
Okay.
Yeah. The way I've seen a nurse practitioners make more money with their experience and degree is to do adjunct type positions like teaching, consulting, where they actually add more. Now, that doesn't mean that you don't get paid more for experience, because as a nurse practitioner with 20 years experience, specialized in cardiology, I'm going to make more. I want to be more at the 90th percentile for income than compared, to the rest of nurse practitioners. So experience and specialty plays a big part in it as well. Family practice there's the billable component and how much you bill that impacts the practice revenue, right? And so if a lot of the things that you see in primary care, if you're seeing more simple, acute, self-limited problems, then whenever you bill insurance, Medicaid, Medicare, that bill is not as high as, say, I may bill someone that I've seen in cardiology that has heart failure, that I've just given medications that could cause them kidney failure, because there's a higher risk. So there's the billing scheme is acute, self-limited, all the way up to very complex and difficult to manage. And so that's how providers bill. So in primary care, you have a mix of those things typically. You have a mix of more simple, less complex problems and situations, and you have more complex, but it averages out at a lower rate in primary care than it might in cardiology or nephrology.
So do you know what are the highest paying fields?
So psychiatric mental health nurse practitioner is the highest.
But that's in its own field. What
It's
about
a nurse practitioner.
Yeah, so one of the fours for family.
So family nurse practitioners that may work in a specialty. So any specialty is going to pay more, but like cardiology might pay more than pulmonary. It really, all specialties pay more, and that family nurse practitioners can work in.
Okay.
Which specialty really depends. It's variable depending upon the specialty and also the location. If it's more suburban versus urban, there's those type factors. Inpatient, do they have an inpatient component to their practice or not? So if it's strictly outpatient, that is seen a little less taxing, less acute care risk associated with the practice. It's outpatient versus inpatient. And so if they do inpatient, they may be paid more. They're also, with that inpatient piece, it becomes evenings and weekend type work. So then pay increases with that. But it wouldn't be uncommon to see a family nurse practitioner that may work as a hospitalist on the hospital service in a suburban setting that might make 160,000 with the practice.
Okay. So it seems like it's common for nurse practitioners to get paid at 100 grand.
Yeah.
And it's really cool. I can see why it's a sought out profession, because most of your school debt is paid off firstly.
Yeah.
And then you're earning 100 grand almost.
It could be, yeah.
Right. And so, I mean, all those other factors that you mentioned, locality, specialty, inpatient versus outpatient, will influence that. But at least you're almost at 100 grand. For most professions, it takes 5 to 7 years of experience before you can get there. And you typically have debt at that time. So you're paying that off for another however many years, depending on the amount of debt you incur. So that's a really big positive.
Yeah, absolutely. And I would say that there's very few family nurse practitioners start off less than 100,000 a year. Where I see nurse practitioners make much less than that is when they work for indigent populations. So those practices are funded by state, federal funds, and they don't receive the amount of funds that maybe a private practice generates. So they pay their providers much less.
What was the indig part? I missed that.
Indigent. So like community access clinics where they're state and or federally funded, where they receive grants, where they receive state funds to take care of patient populations that don't have insurance. So that patient population, unfortunately, they're a very complex population, and the provider doesn't get paid. The practice oftentimes cannot fund to pay, at the 50th or 75th percentile for the provider. So they may offer or pay their providers closer to the $80,000 annual.
It's still not bad.
It's not bad at all. Not bad at all. But it's a very complex patient population because they don't have access to care.
Yeah.
And so the work is not any easier,
Yeah.
but the pay can be less.
Yeah. But you might get much better experience.
Yes, absolutely. Yeah. And care, absolutely.
All right. Where do we want to go next? So I always like to ask this question. Are there any special perks to being a nurse practitioner? For instance, as a nurse, a lot of them work 3 days on, they have 4 days off. And, every profession has something that you wouldn't know unless you actually join the profession. So are there some special perks to being a nurse practitioner outside of being the #1 ranked job in the United States?
The job satisfaction. So the perks are, one of the things I think is a great perk with being a nurse and a nurse practitioner is the flexibility and the opportunities within once you have that degree and experience. So my husband was in the military, and we relocated every 4 years on average. So I worked in Ohio, or I got my education in Ohio. My first practice was in Iowa, and I then moved to Georgia and practiced there, and then to Northern Virginia and practiced in DC, and then we moved to Central Virginia. So the demand there was lots of flexibility. So as a family nurse practitioner, I worked in family practice. I worked in private cardiology practice. When I went to Northern Virginia, I worked in the inpatient cardiovascular service, and then I worked in the outpatient cardiac clinic. And then I moved to Central Virginia, and I worked in cardiology as my practice. And then I worked in academia. There was leadership opportunities. And so there's lots of opportunity for growth. As far as perks, I would love to say, if you work in medicine, you can ask your friend for a prescription if your kid's sick. But that might have been the case back in the day, decades ago. But now more than ever, there's more prescription oversight. Providers are, and truly, you should a patient should be established as your patient so that they're not getting care from multiple different providers, right? And there are state laws that mandate that you have charts on patients and that they be established with you. So you're not there's none of the side prescriptions.
No hookups.
None of that any longer. I think there probably was a good amount of that before. But I wouldn't ask a colleague to do that, but there are the educational perks. every year I get time off from work that's paid to go to continuing education. They pay for continuing education. And the stipend can be very good, and paying for the extra things I need, like my stethoscopes or my lab jackets and things like that. Which, honestly, coming from being a nurse, the hospital system didn't pay for any of that for me. I had to pay for my license. I had to pay for my equipment, my scrubs, everything like that. But then, as a nurse practitioner, I've either the practice has been generous in that they're like, hey, we're going to give you a stipend for this and pay for all of these things, or I've been able to negotiate that in my contract to where it's paid for. So one continuing education, like they'll pay for my flight, my hotel, my conference fees, all my food while I'm gone, and they'll pay for the whole thing, which can be several $1,000s and the time off for it. So I think that's coming from being a nurse, that was a pretty good benefit, I felt like. And the work conditions, yes, the work conditions, I believe, are one of the reasons why nurses go in to be a nurse practitioner, is because it is more of a 9 to 5 type position, to where they can be home, in the evenings with their kids. The office is closed on holidays, and so they can be home for the holidays, versus whenever you're a nurse, there is a lot more flexibility than there was when I was a bedside nurse. But you still, if you want to be, a good team player on your nursing unit, like, you're not going to say, you're not going to be working. You're going to have to work weekends and holidays at some level, unless you're a traveler and, you do some different arrangement. But not having to do weekends and holidays was a big perk, I felt like, in the continuing education. Yeah.
Seems like a lot. Seems like a good profession.
Yeah, it is.
So just for your personal opinion on the profession, what do you like or love about being a nurse practitioner? I
love the ability to impact patient health and outcomes and work with patients to achieve their health outcomes. I love the opportunities for learning. There is always learning in healthcare, and the story about the physician, where I asked, when will I ever know this, or how will I ever get this? And he said that's why they call it the practice, and it's because you're always learning. And that was year 1, and then year 10 into it, and I'm in cardiology, and I go to my chief of cardiology, and I say, Dr. So-and-so, I've never heard of this condition. Where did this come from? And he asked, like, when will I stop learning about new conditions? He's like, never. Like, there'll always be something new. Like, there's always this rare new thing. So that I love that there's always learning, there's always improving, there's the satisfaction of helping patients and contributing to society that way. Yeah.
That's cool.
And there's so many opportunities. I mean,
well, you're here to advocate on behalf of nurse practitioners, but I do have to ask you, what do you not like about the profession?
Well, I think that the profession have not always been good advocates for the profession. I think that there have been lots of advocates. There have been lots of nurse practitioners that have been great advocates for the profession, but overall, I think nurse practitioners don't advocate for the profession, and I think we see that in our practice acts and requirements and restrictions, and we also see that in our salaries. Our salaries are listed 23rd in U.S. News and World Report, and I think that's because we are not good negotiators or advocates for our value. So I see that as an opportunity for nursing, the nurse practitioner profession, and nursing, as a matter of fact.
You should call some lawyers.
I know,
We'll
exactly.
help you.
That's right, yeah. Be good negotiators. Yeah, we should work together, collaborate. Yeah.
Let's do it.
Yeah. So I think we should advocate better for our profession and take better care of ourselves. We tend to put patients first, families first, practice first, our jobs first, families first, and everything first, and we put ourselves on the back burner.
Self-love is not a thing.
Not.
All right. Well, so we discussed this earlier, and you mentioned we were talking about adjacent and tangential roles. Mm-hmm. So you were telling me when we were not recording about the role of a physician assistant. What are some roles that pop up once you become a nurse practitioner, or even when you're a nurse, that someone might want to consider?
Yeah, I think one of the most obvious is that there's a nursing shortage, nurse practitioner demand, and there is a nurse practitioner and nursing faculty shortage. I think so. That's one of the most straightforward and impactful opportunities for nursing and nurse practitioners is to go into education. And we need the reason we have a nursing shortage is because we don't have enough nursing faculty. So I think that's one area where there's great opportunity for nurses and nurse practitioners is in academia. There's also, healthcare administration and leadership. Those opportunities are less robust and available. There's consulting. There's legal nurse consulting. That's one opportunity. There's consulting for healthcare systems. Yeah. So I think education is probably one of the more straightforward opportunities for nurses, and there's a plethora of opportunities because of the shortage.
Fair enough. What about the role of a physician assistant? Is that a similar track through nursing, or is that a completely independent route?
It is absolutely independent, and this is the physician assistant typically comes from a background of having a bachelor's degree in something like biomed, biology, chemistry, some type of science bachelor's degree, and then they can be admitted to a PA program. PA programs, many of them are master's programs, and they are 2 to 3 years. There are doctoral PA programs. They can be little more than 3 years. So you can be that can be your second career. You could have a career in something totally different. You could do prerequisites in science, and you can go into a PA program, and you can be done in 2 or 3 years and be practicing as a physician assistant. The differences are physician assistants are from family nurse practitioner. Physician assistants are their training education includes more inpatient and procedures than do family nurse practitioners. A lot of the physician assistants I work with, both inpatient and outpatient, but a lot of them love the inpatient side, whereas I see nurse practitioners, everything's personality based, but generally speaking, nurse practitioners like the outpatient side to take care of patients. That's more of their area and scope of practice is outpatient management. So physician assistants, more procedures, more inpatient, hospital based care, and they haven't had the exposure to the healthcare system before they enter their education. So that is a little bit of a disadvantage, but the outcomes, they have good outcomes. From a practice standpoint, nursing is its own profession, and it regulates itself. Physician assistants are regulated by the medical boards, whereas in many states, nurse practitioners have autonomous practice. Physician assistant may have to have a collaborative agreement because they're regulated by the Board of Medicine.
I will have to invite a physician assistant
Yes.
and get a robust understanding.
Yes.
It seems to be a career on the rise as well.
Yes.
All right. So now that you have 20 years of experience, you've been a nurse, you've been a nurse practitioner, you've been in academia. What advice would you give to yourself when you were starting off as a family nurse practitioner?
Yeah, I would tell myself to establish a relationship with a great mentor, one that would help me learn the ins and outs of how to manage the time management, patient loads, complex patients. That's in career. So professional, not just taking care of patients, but also what are the opportunities in my career. I didn't necessarily understand the need for nurse educators, when I was a nurse practitioner, or the opportunity there. So having mentors is an important thing. That's what I would tell myself. Find one early and engage frequently.
Mentors are hard to find. Any advice you got on how you would go about that now that you have so much experience?
Absolutely. As a family nurse practitioner in your first position, as you're going to be assigned some type of mentor or preceptor, someone to help orient you that's a provider in your practice. I would start with that person. If that person is willing to be, have conversations with you over the lunch break, or over dinner once a month or once a quarter, to really kind of reflect and help you grow in your role. That would be a great opportunity. The other place I would say to start is to join your regional, local nurse practitioner professional organization. They are every state has a nurse practitioner organization, and every state has regions where there are groups of nurse practitioner professionals that meet on a monthly basis, and they are there to advance the profession, and they are great mentors. They love the profession, they love the collaboration, and they are great. They're great mentors. That's where I would start.
Awesome. It's a game changer once you find a good mentor.
Yes,
And
yeah.
I've noticed that in my career as well. So go find a mentor. Now, I close off all my podcasts, and you said you've already prepared for this. So I would just like a short answer to each one of the following questions. First and foremost, what is the best career advice that you have received? It doesn't have to be nurse practitioner, just in general, what is the best career advice that you ever received?
To be a nurse, because there will always be people that need nursing care.
Okay. All right. And what is the worst career advice that you have received?
Be a nurse, because there will always be people that need nursing care, and you'll always have a job. So on one hand, it's truly one coin, two sides. The best advice is that nursing is a very rewarding career, and being a nurse practitioner is very much theoretically, practice-wise, still nursing. There are lots of great opportunities, and there's job security. Those things are all true. But if you do it because there will always be a job, then I think that you're doing it for the wrong reasons, and you will not find satisfaction in your career. So and I have gotten that advice from the same people, so the same person. That there really is, it is a great profession, and there's great opportunities. But you really want to make sure that you're doing it because you want to help people. Otherwise, you're not going to find satisfaction.
Okay, makes sense. Well, thank you so much for all the insights that you provided on this profession. I think after watching episode 6, and this will be episode 7, people will have a very strong idea of how to enter the nursing profession, what to expect as a nurse, what to expect as a nurse practitioner, all the different routes. I will seek to find the other 3 types of nurse practitioners, and we will discuss those as well. But it was really, really awesome to have you here. Thank you.
Well, thank you very much. It was great to talk about this awesome profession. Yeah.
Well, that's it for this episode of the My Career Shop podcast. Thank you for tuning in, and I hope you have a better idea of how to become a nurse practitioner and what to expect once you actually become one. Details about this episode and the career of a nurse practitioner are on the My Career Shop website, links to which are either in the description below or show notes based on where you are watching or listening from. If you haven't already, please hit the subscribe button, leave a review, and comment on what professions you want me to invite next and what other information you'd be interested in listening to. Until next time.